My topic is on dangerous passage. So, Mr. PG, who is an 64-year-old farmer who is a diabetic, present with the complaints of right-sided facial pain for 6 months, with decrease of vision for 3 months, and a complete loss of vision. 3 days. There's no history of dry eyes or any pain on eye movements, no history of any fever, loss of weight, loss of appetite. He had a history of right paratectomy in July 2023, and also he underwent coronary angioplasty in August 2023. On examination, his vitals are stable. And on cranial nerve examination, on right side, right cranial nerve 2, there is no perception of light, and there's partial ptosis of the right eye, and the eye movements were restricted in the lateral gaze. Cranial nerve 5 is normal. Cranial nerve 7, there is a deviation of the angle of mouth to the left side. Other cranial nerve examination is normal, and other systemic examination also is normal. Now, based on the above clinical syndrome of right-sided facial pain and loss of vision with the involvement of cranial nerve 2, 3, 4, 6, and 7, the following differentials were considered, which is orbital apex syndrome, superior orbital fissure syndrome, and cavernous sinus thrombosis. Now, the probable etiology considered was invasive fungal infections or any tumors, and the anatomical localization was to the orbital apex. Now, how do we clinically differentiate orbital apex syndrome from superior orbital fissure syndrome and cavernous sinus thrombosis, because they're almost in the same area? The major thing is involvement of cranial nerve 2. In orbital apex syndrome, there is involvement of cranial 2, whereas in superior orbital fissure and cavernous sinus syndrome, there is usually sparing of cranial nerve 2. And in cranial cavernous sinus thrombosis, there is also no involvement of the maxillary division of the fifth cranial nerve. So for our patient, an MRI was done which showed a soft tissue mass in the right maxillary sinus, which was eroding the posterior wall, superior wall of the ethmoid sinus, and is extending to the orbital apex and the cavernous sinus with dural infiltration. So we have gone ahead and done an ultrasound guided biopsy, and the biopsy report came as acute invasive fungal infection with septate fungal hyphae resembling aspergillus. So I want to talk about a little bit about orbital apex syndrome, which is also known as Jacquard syndrome. Now, if you look at the orbital apex anatomy, so it contains of annulus of Zen, from which the 4 recti muscles take their origin. There's also optic nerve, ophthalmic artery within the optic canal, and the superior and inferior divisions of the oculomotor nerve, abducens nerve, and nasociliary branch of the fifth cranial nerve. Now, the conditions which can lead to an orbital apex syndrome, they are inflammatory conditions, tumors, trauma, infections, and vascular conditions. These conditions usually present in an acute setting and usually progress in days. And they are SLE, granulomatosis with polyangiitis, microscopic polyangiitis, Struck-Strauss syndrome. And there's something known as Colosa-Hunt syndrome, which is also an autoimmune condition where there is painful eye movements with significant ophthalmoplegia. Certain tumors in the brain, like schwannoma, meningioma, also can cause orbital apex syndrome, and infections, especially bacterial and fungal, are the major causes. The viral and parasitic are rare causes. However, there are report cases. Cases were reported. Now, they usually present with a painful external ophthalmoplegia with proptosis, decreased vision, RAPD, anisocoria with optic disc edema, facial pain, and paresthesia. So during our COVID-19 time is when we have seen a lot of cases of mucor, and they usually present with many ophthalmic symptoms like cellulitis, orbital apex syndrome. So here is a study done during COVID-19 which shows the increasing incidence of orbital apex syndrome, and the major causes of them were mucor and aspergillus. And diabetes mellitus was found to be the most common cause of immunocompromise in these patients. This is just an article just to say that there are many cases reported on orbital apex syndrome secondary to fungal sinusitis. After the diagnosis, we have gone ahead, done an endoscopic sinonasal debridement, and the biopsy also proves an acute invasive granulomatous fungal rhinosinusitis. He was started on voriconazole, and on day 7, we have done an voriconazole trough levels and was discharged on oral voriconazole. He's currently stable and is on regular follow-up. So the learning points are: how do we clinically differentiate orbital apex syndrome from superior orbital fissure syndrome and CVT, and to think of invasive fungal sinusitis as a differential for orbital apex syndrome. Thank you.
Thanks, Sharon. Any questions? Thank you. I think we should move on. The next one is by Medicine 5, Dr. Brightus, heavy heart.